Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep, here we go. You know, it's sort of interesting what he was saying there. We're talking about the care. And boys, there have been some paradigm shifts in the way we care for vein care. Modern vein care is not like the old gray mare ain't what she used to be. As a matter of fact, it's in this day and age, since we make these automotive comparisons on being, operating on solar power and operating on anything but gasoline. If you've got that old Henry Ford thing sitting in the garage and you're pouring money into maintaining it, those days are over. So what should be your expectations? Well, that's what Dr. Juliff and I are going to talk to about. Mainly because I think almost everybody in shows that we've done before, Doc, have some sort of recall, particularly once they find out that venous insufficiency is quite a lot, most of the time, hereditary. And their immediate reaction was, nope, grandma or grandpa had that, that's not going to happen to me.
Yeah.
Yeah, and that's a shame, isn't it, in a way?
It is, because it really has placed sort of a cloud over vein care just in general.
Let me ask you this. Here's the real good one, because sometimes I liken it to dentistry. You almost used to, when I was a kid, you could almost see the drill going around.
Oh, yeah.
I mean, it was like, and it would stop every now and again. The dentist would be, now there's such high speed, you don't even know when they're done.
Right.
So I'm going to say that although there are certain, parallel similarities here, in the way you treat varicose veins, spider veins, deep veins, all these veins, way, way different.
Yeah. And that's, it's been a tremendous benefit. But yeah, getting back to people who feel like it's still in the dark ages and they remember grandma being, having her veins done and it was such a terrible experience, et cetera. It is one of the things that we fight. And we do need to educate people with what's out there right now. But
that's what we're here for, really.
Yeah, exactly.
But gang, here's the thing. And I think, Doc, if you could explain this. It's not that the old ways were awful, but everything's changed in the right direction. And it's mostly because of technology. So maybe you can incorporate, we can say back then they did this, today we do that.
Right. We do very little, if any, actually, surgical vein stripping anymore. And that's the procedure that everybody's heard that, their auntie or their grandmother had. And that was a procedure that people were admitted to the hospital for. It required a general anesthetic, which in and of itself adds a fair bit of risk to the overall procedure. But people had a bunch of little incisions all over their leg, and fair amount of bruising and discomfort and whatnot that lasted for a good while, and they were in the hospital 2 or 3 days.
Oh boy! Now, can you imagine? Right now, this is the time of the year where we're all like hugging family and seeing people we haven't seen for a while. So there's going to be, especially here, there's going to be shorts and short skirts and people rocking around and somebody saying, "Auntie, what happened to your legs?"
Right.
Auntie, if she's got any sense in these days, can say, "You know what? I'm not going to do that. Next week, I'm going to go to Dr. Juliff's office. I'm going to get those nasties taken away. So when we get together with the party, I'm in shape." That necessarily is an expectation people shouldn't have. In other words, certainly you can do this, but what about, how soon is it going to go away?
Yeah.
And isn't so? In other words, that was the worst question I've ever asked in my career. What I'm really getting at is that people have this thing that they cling to, and they're just not warranted anymore.
Yeah. Well, and that's why I wanted to talk about this a little bit, because everybody has a little different set of expectations of what, vein care is all about right now. Everybody knows what it was in the past, and they know they don't want to have it done like that again.
Oh, yeah.
But it's a wide range of people, of various ideas of people that what they have when they come into the office, and they, many people feel it's going to be, a one-day thing. They come in and they get evaluated. We do a few injections here and there, and it's over.
Yeah.
But no, it's not that easy. It's a little more complicated. But, all of the procedures that we do these days are minimally invasive.
Okay, let's talk about the minimum vein. Let's talk about a spider vein. Have there been changes in even the dealings of spider veins?
There has been. Mm-hmm. Yeah, there has been. In the old days, we used to use primarily something called hypertonic saline. It was just a concentrated salt solution, and that was used to close spider veins. Now we have things that are the medications are a little different. They don't hurt quite as much. The response is a little better. That kind of thing. So yeah, even with spider veins, therapy has gotten better. But everything we do in the office. We don't really make incisions anymore. Most of the stuff that we do is just through little needle puncture sites.
You know what, gang? This is what you've heard us say before. This is what the doc calls an entry site. To me, it was like, oh no, it's a hole. But no, it's because of the technology and the tools, that entry can be very, very minimal.
Very small.
Yeah, that's great.
And so healing time goes way down. And people don't have a bunch of, scars on their legs from the little incisions that they used to do. So we do everything in the office. We do some, rather than general anesthesia, we do something called tumescent anesthesia.
Okay, what's that?
And that's a newish kind of technique. Now it's been around for a number of years, but it's sort of a fancy form of a local anesthetic, kind of like what you get at the dentist.
And that's exactly what I've had, lately. And that's what I wanted to talk about a little bit because, like you said, in any surgery of any kind, if you're using a general anesthesia, there are risks involved with just that.
Absolutely, yes, and that was a huge step. And now there's a whole host of things, a whole host of various outpatient procedures that we're now using tumescent anesthesia on or for. And that was a big step. Taking all of those procedures out of the realm of in the hospital, general anesthetic, et cetera, and transporting that those procedures to be able to be done in the office with this thing we call tumescent anesthesia, and really nearly virtually eliminated all of the risk of a general anesthetic.
Yeah, and there's another one every now and again the doctor will say, little poke. And they really are. I mean, that's what a dentist used to say when he was lying to you about putting that Novocaine in. But even now in a dental practice, we've learned from our dentists that it is the same thing. The needles are smaller. The penetration is way less invasive. The medicine that they're putting in your teeth is stronger. You don't need as much of it. And it sort of mirrors what you do.
It parallels. Yeah, very much so. But we do the procedure and, compared to before when people were stayed in the hospital for 2 or 3 days, people come in for the procedures that last about an hour, and they go home with a gauze wrap on their leg, and invariably the infamous compression stockings. But they leave the hospital and go on with their day.
Yeah, that's another thing, and I've heard this said, okay, doc, I want to do this, but how many days do I have to take off work?
Right.
Well, the bad news, if you thought you were going to take a few days off, is none. Yeah. I mean, you're going back to work.
Yeah.
Now, but there are certain things. I mean, typically, and I would imagine you can explain that, depending on the severity, if you will, of the procedure, or the amount of things that you're doing all at one time, maybe it would be not a good idea to go straight back to work the next day if you've had a lot of work done.
Yeah, well, that, but also the kind of work that people do.
Yeah.
We try to discourage much heavy lifting for about a week after we do procedures.
Good.
And because that does affect the outcome. So if for those people who are in professions where they're lifting heavy things or pushing, pulling, that kind of thing, heavy kind of physical activities, then we try to have them take a few days off, but nowhere near as much as what they had to before, and they really don't. Other than lifting, I mean, lifting is the only absolute restriction that we have now. There's some swimming restrictions.
Sure.
But from a physical standpoint, that's about the only absolute restriction. otherwise, people can really do pretty much whatever they feel like they're comfortable enough to do.
Here's what I really get a kick out of, because we talked about this in previous shows. And sometimes you see in the bodybuilders, they're very, very lean body fat. And their veins protrude a little bit as it is. And before a pose down, or whatever they call them, when they go out to get judged with the oil all over them, they'll do the biceps and they'll do the pumps.
Oh, yeah.
Well, they'll actually, those veins will actually swell up.
Yeah. Oh, yeah.
And what is that? With more blood going there? I mean, how come they do that?
Yeah, a couple of things.
Pressure.
Yeah. That and just the activity, the muscular activity. Mm-hmm. There's more, blood going to
rushing
the muscles
there,
as they work them more, and then obviously the blood's going to have to come back out through the veins. But also, they're heating up their body, and
sure.
I think that most people have seen that. When you get warm, that's when your veins really pop out.
I got to laugh because there was this one guy that said, sometimes they'll get so dehydrated prior to a pose down or whatever you want to call it, is that they want to look as svelte, as slick, and as muscled, and they sometimes the second they get off that stage, they just practically need an IV of liquid or something.
Exactly. Yeah. I've heard that myself too. Yeah.
But that's another thing. And so one of the things that I hope you've noticed is, by the way, and look, you can walk over to veinclinicsofhawaii.com anytime you want, and you can check into this stuff. You can email, you can ask a question, you can make an appointment, you can do all that stuff. I don't know, we didn't tell you this program, but I tell you every week that Dr. Juliff's offices are on the Big Island, on Kauai, on Maui, and here on Oahu. So you neighbor islanders, you're part of the deal. Although we do the show here in Honolulu, one of these days we'll have to go over to your island and do it. But I still think that people, even though you tell them all these things, they just can't believe it. So it really does take sort of a consultation or a visit so that you can find out. Say, what you might say to me, "Hey, Mike, what are your fears?
Mm-hmm,
are you nervous about any of this? Let me help you out here a little bit."
Yeah. Well, we do a lot of that.
Yeah.
I mean, we do a lot of managing anxiety. There's no question about that. So yeah, when people come in, it's not only we're evaluating them from a medical standpoint, and focusing on their venous disease and how we're going to take care of it, et cetera, but everybody will ask, "Gee, doc, is it going to hurt?" Mm-hmm. and which I always respond, "Gee, it's not going to hurt me a bit, but I thank you for asking."
Yeah. But let's get one thing understood. I don't want to hurt. Now, I do know that everybody's pain tolerance is different, and we've talked about that a lot of times. But I think, because of what I already know about your practice, that, maybe some people, they just need a little anesthetic. They just need a little, help. Some people need a lot more. But it's not general. It's always going to be sort of local. Yeah. And so far, the treatment, the only issue I've felt is a little pulling and tugging, but certainly no pain.
Yeah.
You're waiting for it to hurt. It's like when people are, once again, sitting in the dentist chair, clutching onto that thing, waiting until you go, ouch. There's no ouch.
Right.
Yeah, this is really good.
Well, and that's, that's the anxiety part of it, because, people, some people handle, it's not that they're handling pain better, it's they're handling more the anxiety of not knowing what's going to happen.
Okay.
And also just going through the procedure. So again, we spend a lot of time managing anxiety. And I think that the people that have, the most problems with going through the procedures are people who don't really know or don't completely understand how things are going to unfold, how things are going to happen. And again, that's why we try to spend a lot of time making sure that they know exactly what's going to happen every step of the way.
Okay, let's go back for just a second to the old vein stripping days. I'm guessing that you couldn't do an awful lot of work on a patient at one time just because of the sort of invasiveness of it. And I think that people need to know, when you talk about vein stripping and you had to actually go in there, sometimes weren't those kind of deep inside the leg?
The veins that we typically surgically stripped out of the vein, out of the leg. Yeah, those were the little deeper veins. They're not the most superficial ones, although we took those out too. But the vein that we used to pull out of the leg, it stays in the leg, and we manipulate it in a little different fashion to bring about the same result. but in a lot less invasive and a lot less traumatic sort of fashion.
Does that mean that you can have more issues dealt with per visit? I mean, time-wise.
Yes and no. But, with respect to your question from before, did we, in general, take care of everything back when we were doing surgical vein stripping with general anesthesia? Did we pretty much take care of everything? Yeah, but we didn't do as complete of a therapeutic plan as we do today.
Well, also, that guy or gal was probably going to be in the hospital recuperating in a few days. It's not, you can't go in and get a vein stripping in your office today in the old way and say, okay, we'll see you in a couple of days.
No.
You got to be down.
Sure.
One thing you said, maybe listeners, if you picked up on this, I wrote this down just so I would ask Doc before we move forward. When you said that there's some restrictions about swimming, I'm curious. What about why?
We ask people not to go into the ocean for 2 weeks, which is a real inconvenience for a lot of people.
In Hawaii, sure.
Yeah. But that's strictly for infection purposes.
Oh, okay.
Because, there's a lot of bad bugs out there. And if you have a little nick in the skin, I mean, even though it's not big, any portal of entrance, people can get pretty bad infections.
No, we're talking about staph. We're talking about a lot of other things that people would avoid, right?
Yeah.
Okay, what about the other side of it? And that is, all right, well, you can go back to work and resume most of your duties. Are there times when, first of all, I'm going to guess that during the vein stripping procedures back in the day, there's probably more blood and stuff and all that in the surgery.
Right.
And from what I understand now, unless you have something really traumatic going on, you're not going to lose much blood.
Very, very little.
That's encouraging.
And a lot of people ask about that, and because it doesn't make very intuitive sense that we're doing all this stuff and they're not going to lose any blood. But one of the ways that this newer form of anesthesia, or tumescent anesthesia, one of the ways that it works is by eliminating a lot of that bleeding kind of thing that might happen if you're not using it. The part of it is just because all of the anesthetic fluid that we're injecting into the leg collapses the veins, so it pushes the blood out. But there's also a chemical in the anesthetic, concoction that we use that actually causes the blood vessels to clamp down.
Yeah, which may be a good thing.
Is it good? It's definitely a good thing.
Because I do know that. Let's talk about some of the ways that when you consult with somebody before they get into treatment. There's two questions here. One is when somebody's got some condition, they're sick, they got a bad tooth infection, they got something wrong with them. This is not a good time to have any kind of surgery.
Right. Sure.
Okay. But the other one is, all right, this person is going to have this surgery. Let's sit down in the very beginning to really, I guess maybe back in the old days, people say, Doc, I'm so afraid of this. I really don't know what to do. Just knock me out and get it over with.
Yeah.
I'll let you just go ahead and fix me. But I think that aren't you sort of insisting now that people learn more about what they have and what their plan's going to be, so they're part of the procedure.
Well, yes, exactly. And we still have a number of people that say that. A lot of people do come in and say, "Hey, I don't even want to know. Don't describe it to me. I don't want anything to do." But really, in the long run, I try to talk to those people as much as possible, maybe even a little more, because their anxiety level is real high.
Yeah.
And it's even more important for them to know exactly what we're going to be doing every step along the way.
Okay, when we talk about and today's program, gang, is sort of subtitled "Expectations of Modern Vein Care," and you can learn about this and other things by going to the website veinclinicsofhawaii.com. Veinclinics, plural, of Hawaii.com. I think we get into it a little bit too. Almost everybody says, well, how complete is it going to be? So maybe the expectation of, and I've been told by you that don't expect that it's all 100% going to go away, because it will in some cases. In my case, I had a couple on the top of my thighs that I had for years, and I thought, they're gone. I can't even find out where they used to be.
Good.
That's pretty good stuff, right?
Oh, that's good.
Yeah. But sometimes, what is the... I was going to say, what is the healing period for, generally speaking, for a varicose vein treatment? Does it take sometimes months for the little thing to go away?
Yeah.
What sort of what sort of benches are we looking at?
And that's one of the expectation kind of points.
Yeah, especially if you're going to high school reunion.
We
you
have
want those legs looking good, right?
Well, right. Yeah. A lot of people come in and they say, "Oh, can you do this today? Because I need to go to my reunion next week,
Saturday."
And it's like, no way is that going to happen because it's just the results don't happen that quickly, you know. And that is one of the expectations, and also. I find that another thing is that, although we're doing everything in a very minimally invasive sort of fashion, we're however, still making a lot of things happen inside the leg. And, we're creating a lot of inflammation and this sort of thing. And that's going to create a little bit of discomfort. Not a lot, but people do have a little bit of discomfort after the procedure. Now, when they go into the hospital and they have a bunch of incisions all over their leg, it's easy for them to look down at their leg and say, "Oh, well, yeah, my leg hurts because of that." Yeah. But the way we do things with just again little needle puncture sites, it doesn't make intuitive sense.
Gotcha. Yeah.
In some cases, that I'm uncomfortable, but I don't see anything on my leg. So we have to educate people about that too.
What about the times when somebody needs more than one treatment on one vein? I mean, I was reading, and we've talked about this before. Well, generally speaking, when you do a procedure, it's pretty much going to have a path of, I'm doing this now, and in a few weeks it's going to start fading away, and in a month you won't even know it was there. But every now and again somebody says, well, half of that one's gone, but the other one didn't seem to go away much. Does that happen?
It does. It depends on kind of what you're talking, what specific kind of problem you're talking about. But that type of scenario would apply more to spider veins. And that's spider vein treatment is something that we have to really manage expectations because everybody wants every spider vein gone, and unfortunately, it's just not in reality like that.
Yeah, I'm glad you said that because that's what everybody asks me. And everybody knows that by and large, and you can explain why this is the case, is a lot of these spider vein procedures are an elective procedure that you're doing. It's a cosmetic treatment. It's not something that you are going to be hospitalized for. It's not going to be something that your insurance company is going to pay for. But somewhere in the middle is going to be, all right, I'm here actually for my varicose veins, and I need varicose vein treatment. At the same time, can I somehow manage these spider veins?
Yes. The answer to that is yes.
Of course.
However, typically we would the treating of the spider veins would be kind of a second step to the whole process, and the reason for that is because some spider veins are what we would call sporadic, which means that somebody just has the tendency to develop spider veins. Yep. They don't have any other venous sort of issues. They don't have varicose veins. They don't have venous insufficiency. They have just spider veins. We call those sporadic. However, often spider veins, since spider veins are just another part of the whole venous system, so they're affected by what's going on in the other veins also. So sometimes spider veins can be due to poor vein function. Otherwise, we call those secondary spider veins.
Yeah, well, interestingly enough, and if you've been listening to the program, I want to tell you that there is no direct correlation sometimes between a whole bunch of spider veins and varicose veins. As a matter of fact, you've pointed out to us in previous programs that just because you have spider veins does not mean necessarily that you have deeper problems with your veins that you don't see.
Right. Yeah. Exactly.
Which must be very comforting for some people.
Well, yeah, they're happy when I mean they come into the office and they know they have spider veins, so they've already identified that because it's a totally visual thing, and then typically we'll say, well, it would be important for us to find out whether or not you have underlying venous insufficiency. Yeah. We do that with an ultrasound, and those people who we then say no, we don't see anything. Yeah, they are happy because they don't need anything further done.
What about when you do that examination And I'm going to guess that there's never anybody that's 100% perfect, no matter what area. Now, I must also say that you've had patients, and you've certainly been referred people that you say, you know what, you just don't have an issue. I mean, you're not a candidate for just about anything. I do know, though, that once you start looking at stuff like a spider vein, aren't you really just sort of managing them? From what I can read and from what I understand from you and others in the past has been, you can get rid of a whole bunch of them, but that doesn't mean that, first of all, the ones you get rid of are gone. But if you've got them in the first place, you might have them in the second place.
Right. And that's the other thing. That's one of the misconceptions that some people have is that, in the treatment of spider veins, they're going to come in, we're going to do a bunch of little injections, and they're just all going to disappear.
Yeah.
And unfortunately, no, that's not correct. Now, typically what I tell people is that the average response is about 60%, 60 to 70%. So when you come in after you have one treatment, then you wait a couple months, and you see kind of where you're going to plateau out at, and usually it's about 50-60% reduction in how visual the spider veins are.
Yeah. Okay.
So then a lot of people will say, okay, how many treatments do I need? Because, since it's not 100%, then, it often it takes more than one. And that is solely dependent on, how many treatments do I need question is solely dependent on how well are your veins specifically going to respond, number one. And number two, where is your happy spot?
I was going to ask you that because a lot of people say, why are you doing this? Well, I'm doing it because I have low self-esteem. I don't like the way my legs look, and I want these to go away so I can get back with the gals playing tennis. And sometimes, and this is certainly not restricted to you gals, because men are equally as vain as you are. We'll tell you about that too. But quite often, some of it is that these gals just hang around with each other. They don't want to be looking bad, and so they'll. But I still think that it's important for them to know that you cannot expect that they're all going to go away completely. And by the way, when you said that earlier, they want to know how long. Well, look how long it took you to collect them.
Right.
I mean, you've been you've seen these for 30 years. I'm not going to fix them in 30 minutes. Some maybe, but not all of them.
Right. And and that's definitely true. The people who do the best are those people who are able to be patient and kind of go through the process. So, if we treat somebody once and we eliminate 60% of their spider veins, they still may not be happy with that overall result. We treat them again, and then we get rid of a few more. But getting back to what you were alluding to a little earlier, we don't cure people of spider veins. It doesn't matter whether they're sporadic or whether they're related to venous insufficiency. We can't we can't cure somebody. We manage spider veins.
Sometimes folks, Dr. Juleff, folks say, if I don't get these treated, are they going to run into other problems? And I'm going to guess if it's a spider vein, that the likelihood is not that they are, but maybe if they get bigger and more of them, wouldn't that say there's probably something else going on here too?
Yeah. And that's a couple of the things that we look at in reference to that is. Are your spider veins not really responding to our therapy very well?
Okay.
Have we done injection sclerotherapy and we didn't get the response that we expected? Or have we treated your spider veins and, in 6 months you've got a whole new, set of spider veins? That often will indicate or be a sign that that person has developed venous insufficiency, and that's kind of working against you.
And that's really what we were really after here. I mean, obviously, a lot of the work that's done at vein clinics, why all of them, is cosmetic stuff, but nowhere near as much as you think. I mean, I think that you've explained it before, that there are certain people that need to look good, and that's part of that is if they're serving drinks around a swimming pool, or they're, doing any number of things where I don't want to say you're scantily clad, but you're scantily clad, and and it would detract or discourage people from really dealing with you on why you're there, because nobody wants to be leg ugly, you know?
Yeah, well, exactly. I mean, nobody wants that, but it's probably even a little more important for those people who, on a professional level, have their legs exposed a lot, and it means a little bit more to them, sure. And getting back to your comment about men, we treat a lot of men for their spider veins. Sure. So, men can be as vain as women. Just overall, men have vein disease nearly as often as women. It's a little higher in women, but probably I would say 40% of our patient population is probably male.
40%. Incidentally, one guy told me that I don't have a vein problem, but I got hit with a bat. This is from getting hit. And I do know that there are times when somebody will have a horrific bruise that will end up causing damage to the veins right in that area. But isn't that one just way we sort of get in a little bit denial? I don't have varicose veins. I got hit with a bat.
Right.
Yeah. Or my legs here down here, they're not inflamed. They're sunburned. There's a little sunburn. It's going to go away. We've talked about that a lot.
Oh, yeah.
Okay. So going on, though, with this expectations and making the transition from spider veins to the next part of the where you fit on the chart of the 6 stages of venous insufficiency.
Right.
And at what point in time does it make sense to really be aggressive at the lower end of that to either put off or eliminate the other end of it?
Mm-hmm, mm-hmm.
I think aren't a lot of people knowing, particularly now that there are so many great procedures. Okay, what are the different ways that you can approach what I've got?
Right.
And
sure.
what should be my expectations on being able to get them all handled?
Yeah. You sort of mentioned the classification, and spider veins are considered the first and lowest class of on that spectrum of vein disease. When we're treating them, they aren't covered by insurance. Insurance companies in general consider them to be completely cosmetic. Although I must say that every now and then we talk to patients who, tell us that, I know they're a cosmetic, but I've got a lot of pain in this area.
I'm so glad you said that, because I actually meant to ask you that earlier. I didn't want people to think that you're never going to get treated for spider veins through your insurance company, because I think that that's where the practitioner, the clinic, the reputation of the doc has a lot to play in it.
Yeah. Well, unfortunately.
But the insurance companies are going to say, well, that's really nice. Too bad.
Yeah. Well, that's their usual response. Even though spider veins may have symptoms connected with them, they still are not going to cover that. But so anyway, that's the first stage of vein disease is spider veins. Second is varicose veins. Mm-hmm. And as opposed to spider veins, which may or may not be associated with venous insufficiency, nearly always, if somebody has varicose veins,
they are venous insufficient.
They have venous insufficiency to one extent or another, and that's why it's important for people to understand that, especially varicose veins, definitely not just a cosmetic problem. It's a sign that there's probably something more going on.
When we talk about diagnostics, and one thing that we talk about on this program every time, and we got to do that here. When a new patient comes in and to get examined, it is so much easier for the practitioners of today to zero in on what the problem is based on the diagnostics of the ultrasound, right? Mm-hmm. I mean, before, wasn't it sort of a guess? We don't really know what's going on in there. We need to take x-rays. We got to put fluid in there. There was a lot of other things that used to happen.
Yeah. Before we had ultrasound, there were, a number of different examinations that were pretty cumbersome. And the disease process was sort of implied, not really, visualized and made in or demonstrated in a very definitive fashion. Or there were, things that were invasive kind of procedures like venography, where we injected dye into the veins and watched it with X-ray. Ultrasound changed that completely.
When you did that back in the day, was somebody lying down, and then you were watching somehow this colorful fluid going up the vein?
Yeah.
Wow.
Typically, yes, but also as a part of that exam, the patient's position would be changed to demonstrate a lack
where
of
the problem
function.
was.
Where the problem was.
Wow.
So, people with varicose veins, invariably they have some amount of underlying venous insufficiency, and we've got to, we certainly have to evaluate them for that, and typically it's done with ultrasound. But the way that we treat varicose veins is something called ambulatory microphlebectomy. And
that one went right by me.
Sounds important.
Phlebectomy to me means swollen. Or
phlebectomy?
No, it's not, right?
Right.
Yeah. That's edema. We know that. But what is that?
Phlebectomy just means that we're removing a vein.
Right. Okay.
Phlebe is has to do with vein. So how do we do that? Well, again, we incorporate tumescent anesthesia. We numb the area of the leg up, completely, so you can't feel a thing. And also we go through little needle puncture sites. And we sort of space those needle puncture sites along the course of a bulgy varicose vein.
Right.
And then through those little puncture sites, we have special instruments that we go in and we take varicose veins out. So we're eliminating them completely. So the overall and ultimate response or result actually is much more complete, I guess, reliably complete, as far as ridding somebody of their varicose veins than ridding somebody of their spider veins.
Is that sometimes because you can diagnose or see a larger area of the vein that you used to be able to see? For instance, I don't think some people know, and I think you've talked about it only a little bit in previous shows, how long some of these veins are that you're dealing with. I mean, some are pretty long.
Yeah, they can be long.
Yeah.
With respect to that, the reason is that the reason it's easier to get rid of varicose veins is because varicose veins are just beneath the level of the skin.
Yeah.
Whereas spider veins are actually
they're in the skin, right?
The
you can
level
see
of
them.
the skin. Yeah, so that's why we can't, because a lot of people will come in and say, "Gee, can't you do something about this?" And then they'll point to a little, a complex of spider veins, and we can't. We would have to get rid of all of the skin in that area to get rid of all the spider veins.
Yeah,
so
wow,
obviously we don't do that. The varicose veins are immediately under the skin. They're kind of connected to fatty tissue, and they come out quite easily. Sometimes they're long, and we can typically we get them out sort of piecemeal. They come out in little segments, but sometimes we can get quite a length out. Yeah,
it's interesting to me is the wow factor or the gratitude factor when it's done. Because I know that people sometimes have extremely high expectations, and you don't want them to be let down.
Right.
So you're telling them in the very beginning, this is what we're trying to do. We can be reasonably sure that the majority of this problem is going to respond to this treatment, but you don't know until later.
Sure.
Whether or not it is all going to go away. But talk about people that are, gracious in little pieces. They get little things done. They're successful in some, but they just know they have to have more.
Right. Yeah, and that's that's the attitude that you have to have when you're treating spider veins. Getting back to you need a little bit of patience. It doesn't happen overnight, and that's the other thing about varicose veins. I mean, treating varicose veins in and of themselves is very rewarding because. One day the patient sees them on their leg,
right, and
then they come in for the procedure, and
they don't see them anymore.
So that makes them very happy.
Sure, you bet.
The reliability of treating varicose veins fair bit higher than spider veins. Sometimes the other thing, most of the time we do phlebectomy. We remove. We're extracting those bulgy veins. Sometimes we do what's called injection sclerotherapy. We inject a medication to make the varicose vein collapse, similar to what we do for spider veins. In my estimation, doing phlebectomy just gives you a little better ultimate cosmetic result. And you can control a little bit more how the patient is going to respond.
What about patients that get that cosmetic result that they want, but then they realize that, okay, now they've been diagnosed with ultrasound, they have some venous insufficiency you're going to deal with. And at that point in time, it's no longer a matter of appearance, that they're concerned about their health. And if they don't get these treated, what can happen next? That's why we talked initially about that scale, that at the very bottom of the scale, vein problem number 1, the spider veins are number 1, but it goes all the way up to number 6. And if you can figure it out halfway up the path, you're better off.
Sure.
So let's talk, what is that becomes a health issue? If you just say, well, you have a bunch of varicose veins, you can do this, you can do that, but these have to go.
Yeah.
Because.
I think once you get to the varicose vein and swelling level, which is the next level up, there's typically a significant amount of venous insufficiency that in general should probably be treated. Now, do we have patients? We always have patients come in and they were unaware of the fact that we're looking at all, we're going to evaluate all the veins in your legs and figure out what's functioning right and what's not. So then we have to have a discussion with them and tell them what we found. And many of them will say, well, is this something that I really have to have treated?
Yeah.
And so the answer to that is, well, no, you don't have to have anything treated. But why are the reasons that we treat venous insufficiency, just in general? But if somebody's coming in with varicose veins, we treat them for 3 reasons. Number 1, and most importantly, are their current symptoms.
Pain, heaviness, swelling, throbbing.
Yes, muscle cramping.
All that stuff.
Restless leg syndrome. Yeah, exactly. All those things. And a lot of times people come in and we find out that they have venous insufficiency that they didn't know of, but they also didn't know that all of the symptoms that they're having are related to venous insufficiency. Yeah. People with varicose veins, that's easy. They know, gee, I've got a bad vein. It's a vein problem. But people with chronic swelling, muscle cramping is another one that we see all the time, especially and it can be terribly debilitating, especially in the older age groups where they're having their sleep disrupted, night after night, multiple times in a night. And it can have a real negative impact on their life. And so we're able to, relate those symptoms to this process of venous insufficiency. And after we fix what they have, they often have, very good resolution of their symptoms, and they're happy,
And by the way, Doc mentioned swelling, and we talk about swelling a lot. We've done shows on swelling. There'll be more shows on swelling. And I guess the good news is that swelling is important because it tells somebody that's swollen, there's something going on here, and I'm not very happy, so I'm swollen. You need to do something about me. Yeah. But one swelling does not answer. This is why I think that people in your profession, and particularly general practitioner doctors, that are now realizing you have to go through sometimes a few different specialists before you find out what's causing that swelling. And it may be more than one symptom, more than one thing, right?
It might be more than one cause, no question about that. And very often it is. One of the things that we have to kind of contend with when we're treating people with venous insufficiency is this thing called lymphedema, and we've talked about that before. But lymphedema can cause swelling just as much as venous insufficiency can. So we're often, treating both at the same time and trying to come up with the best treatment plan for the patient. But the healing time with varicose vein treatment is a little longer than spider vein. And that stands to reason because of the fact that we're addressing the underlying venous insufficiency. And, the other question that we get is, well, just get rid of my varicose veins and I'll be happy, But
I'm guessing, wait a minute, I'm guessing something that in the very initial spot, somebody might feel that. But when all of a sudden the symptom goes away and they start feeling a little bit better, they're going to say, you know what, can we do a little bit more because I'm having a good result. And I know right now that a lot of our listeners are people that have retired because of discomfort and mostly in their legs, and they just don't feel like walking and doing the things that they used to do. And they find out that what they did was maybe partially cosmetic and partially from a symptom, but hey, I feel pretty good all of a sudden. I'm doing things that I haven't been able to do for a while. So is there more that I can have done that'll help me even more?
Well, that, and then also with respect to that question that we get sometimes from patients, can we just get rid of the varicose veins? Yeah, we can, but that's not addressing the underlying problem with the veins that are not functioning well, the veins that are deeper in the leg, the veins, the vein failure that we refer to as venous insufficiency. If we don't correct that also, then varicose veins are just going to come back again in the future, and the same problem is going to be there.
Yeah, and as we're living longer, my friends, and we've learned this before. As a matter of fact, we had a delightful gal and a patient that was spending a lot of time with us in her 80s and doing a whole bunch of things that she was not able to do before she had her situation looked at and handled, particularly when we talked about before, and that was traveling and moving around. But I still think that maybe sometimes by the time we get up in age where varicose veins are a real problem, they're symptomatic and they really need to be treated, there's also a lot of other things going in that same body. And you have to take a look at the whole picture. You might have to see several different people.
Yeah, absolutely. Especially as it pertains to swelling, because like we said, often there's more than one thing going on. But when we look at the symptoms of venous insufficiency, and this is the other thing that kind of goes into expectations, there are several symptoms that are very, very reliably treated by the procedures that we do for venous insufficiency, and that's achiness, heaviness, and fatigue.
Yeah, and all three of those things mean different things to different people. So if you're just coming across the show and wonder who are these people and what are they talking about, Dr. Randall Juleff is the medical director of Vein Clinics of Hawaii. They're on Maui, on the Big Island, in Kona. The Maui, the Big Island, Kauai, and here on Oahu. And Dr. Juleff is the medical director, and we talk about this every single week, different ways you can find out what's going on in your body, and more importantly, how to sort of deal with them so that it's all about really, and you said this before in many different ways, it's really the quality of life that changes for the better when you address any disease, particularly one that you might have had going on in your body for 30 or 40 years unchecked.
Mm-hmm, yeah, and like we've said before also, the symptoms of venous insufficiency come on very, very slowly and over a very long period of time. So people kind of are able to rationalize them off. And I can't tell you how many times we have people come in and they say, oh, well, I just thought I was getting old, Yeah. But you don't necessarily have to have these symptoms in your legs just because you're getting old. There's often a medical reason for it.
Yeah, and some of it, we've talked about this before. Some people are just, I want to say, lucky. They just don't have an issue ever. And yet some of us, thanking our ancestors and our parents and grandparents, you're going to get into this. But that doesn't mean that you have to succumb to it. Don't a lot of patients come to you and say, the only reason I'm here is because I remember what my mom went through, and I just don't want to do that. So how can we tell from what you already know what she has, how can we find out what's going on with me?
Mm-hmm. Well, that's that. A lot of people will come into the office and say just that. Mm-hmm. They remember what their mother or their grandmother looked like, and they have sort of the beginning signs of vein kind of issues, and they want to take care of it early because they don't want to get like grandma. So that's one of the things that brings people into the office.
I'm even worried that sometimes grandma will tell the daughter or the granddaughter, "Oh, don't do that. It really hurts."
Sure.
I had some terrible time with it. But isn't it sort of funny that as some of these folks are really ignoring or being in denial about it, when they finally do come to a moment, they find out, holy smokes, why didn't I do this earlier?
Yeah.
This was fine.
Yeah. And a lot of people say that after we treat them, they say, gee, I didn't understand how bad my legs really felt because they feel great now. But, they don't, again, those symptoms come on. so slowly and over a long period of time that we're able to rationalize it as being something else.
I'm glad you said that, because I want to just give you a little bit of experience. My wife and I were walking around in the store the other day, and there was a couple in front of us, and they were both having trouble. And, we don't want to say anything because, they're within earshot, but I'm thinking, bad hip. That guy's got diabetes. And my wife said, they have that lady. She's using the cart for, support. Mm-hmm. And isn't it true that these things happen so slowly, and so some people don't even understand, don't even think they're limping? That's just the way they walk.
Absolutely.
Yeah. And somebody say, hey, Bob, why are you walking funny? What do you mean funny?
Yeah.
Because you're compensating.
Sure.
You're doing something.
Right. Yeah.
But I think that mainly what we wanted to accomplish today, folks, the expectation of modern vein care, just to plant the seed that there have been so many improvements in all of our lives, in everything that we do. It's not only safe to assume, but it's true that a lot of these things that we're talking about today, they just weren't available 20 or 30 years ago. And 20 or 30 years ago, I guess, in Dr. Juleff, in your opinion as a medical director, that goes by in a blink.
Oh, yeah.
All of it. But I think that now people that get treated, if they never knew what went on to anybody in the past, they're never going to be afraid. What we have to do is get to that group that is afraid and say, stop being afraid.
Right. Yeah. That is so true. I think the people who have this idea of how vein care happens, and the picture of grandma comes up, it really gets in the way of us being able to help people, because there's a lot of people out there with venous disease, and with a lot of symptoms that we could be helping. Like I mentioned, achiness, heaviness, fatigue. Those are very, very reliable symptoms. Another symptom that is common is muscle cramping. We mentioned that before. And again, muscle cramping can impact the quality of life. Now, can we reliably reliably predict that we're going to eliminate muscle cramping as frequently as the other ones, achiness, heaviness, fatigue? Well, no, not as much.
I'm worried, and thank goodness you can't self-diagnose yourself on the internet and perform procedures. Yeah. But there's a lot of people that they will identify something like you said, that it's pain, but it's these night cramps. Well, just take potassium and you'll be fine. Mm-hmm. Take a bunch of potassium. Yeah. But then if you read the potassium label, it says, you better check with a physician before you take more than 40 of these or whatever it is.
Right.
One aspirin is good, 5 aspirin not so good maybe.
Yeah.
But what we're talking about here at Vein Clinics of Hawaii is that you do a multiple different way of diagnosing and treating. So somebody needs to come in and find out where in that category, where in that spectrum they belong.
Mm-hmm. Right.
And so, when somebody makes that first call, what happens?
Well, when they make their first call, they make an appointment to come in and see us, and we evaluate them. We do a complete history, what's called a history and physical. We find out what their past medical history is. We find out what their family history is, because that's very, very important too. So we go through all the usual, gestures and questions and questionnaires and et cetera, et cetera. And then, ultimately get to an ultrasound to, figure out exactly what's going on from a functional standpoint. But another symptom that people don't know about as being related to venous insufficiency is something called restless leg syndrome. Mm-hmm. And
you see that all the time. I was in the mall the other day, and there's this kid, and his leg was going just 90.
Yeah.
Yeah. And it happens to all of us a little bit.
Yeah.
But if it's a what causes that, and is it sometime linked to venous insufficiency?
Yeah. Well, with the kid with the leg going 90, that's more of a nervous leg syndrome, not necessarily restless leg syndrome. But restless leg syndrome is something that typically we talk about sort of involuntary movements of your legs that occur especially at night.
I was going to say, sometimes when I had them, they woke me up.
Yeah, exactly. And it can wake you up from sleep. it's another one of those things that eventually can impact your quality of life, just like muscle cramping.
Well, I just made a big note. We're going to have to reconvene at another time and talk about restless leg syndrome and really categorize that. But in the meantime, I hope that what you've learned today in the program is a little bit more. Today's program was called Expectations of Modern Vein Care, as opposed how it used to be in the old days. And if you want to know more about this, it's a perfect time to go to veinclinicsofhawaii.com, veinclinicsofhawaii.com, and learn a little bit more, because everything you learn is going to make you have a much better life later. So thanks for listening. We'll see you next time on the Vein Clinics of Hawaii show.
Well, that's our program for today, and we certainly hope